Hello everyone, I am Dr. Chandrasekhar, Assistant Professor, Department of Respiratory Medicine, Chettinad Hospital and Research Institute. In this session, we will be dealing with obstructive sleep apnea. At the end of session, we will have a brief insight on definition, clinical features, different traits of OSA with case scenarios, pathophysiology of OSA, consequences of OSA with summary. Introduction. The history of OSA dates back to 1830s, where Charles Dickens in his paper The Pickwick Papers featured a fat boy Joe, a chronically obese character who would fall asleep spontaneously, snore loudly and show signs of profound lethargy. In 1956, Dr. Charles Burwell described a terminology called as Pickwickian syndrome, where there is a classical triad of obesity, excessive daytime sleepiness and hypoventilation. The major breakthrough occurs in late 1960s and 1970s after discovery of polysomnography. They proved that the core problem was collapsibility of upper airway during sleep, which is not attributed by problem of obesity alone but multiple factors involved in the pathology. OSA is a chronic medical condition characterized by repeated episodes of partial or complete collapse of the upper airways during sleep, which leads to cessation of breathing and oxygen deprivation. The physiological requirement. This episode causes either a cessation of airflow, which is called as apnea, or a significant reduction in airflow, which is called as hypopnea. A significant drop of more than 3 to 4% in blood oxygen saturation, a brief arousal from sleep. To be clinically diagnosed, a patient must meet two criteria, that is symptomatic presentation and polysomnography confirmation. In polysomnography, we will describe about AHI. What is AHI? The apnea-hypopnea index is a key metric used in diagnosis and management of OSA. Calculation. AHI is calculated by counting the total number of apneas and hypopneas divided by number of hours of sleep. The normal AHI will be less than 5, while the mild obstructive sleep apnea will have an AHI between 5 to 15, while moderate OSA has 15 to 30 and severe OSA has more than 30 AHI. The clinical features includes nocturnal symptoms, daytime symptoms. Nocturnal symptoms. The nocturnal symptoms includes loud habitual snoring, witness apnea by partners and choking or gasping, restless sleep, night sweats, nocturia. The daytime symptoms includes excessive daytime sleepiness, neurocognitive defects, mood disturbances, morning headaches and unrefreshing sleep. So, we are moving on to different traits of OSA. See, the OSA is not a single disease but a combination of 4 measurable physiological traits, which is called as endophenotypes. The patient may have one dominant trait or a mix. The 4 important traits of OSA are airway collapsibility, ventilator control or called as loop gain, arousal threshold and pharyngeal muscle responsiveness. The first important trait is airway collapsibility, which is anatomical and structural factors. The airway collapsibility is a core component where the upper airway, especially pharynx, collapse during sleep. The main important driving factors are obesity and craniofacial abnormalities. See, we could see an obstruction of the upper airway mainly due to the fat infiltration in the neck. So, we have a first case scenario. A 65-year-old retired bank manager came with the complaints of excessive snoring and excessive daytime sleepiness. On examination, he is morbidly obese with a BMI of more than 43.7 kg per meter square and his neck circumference is 17.5 inches and Mallampatti class 4, that is only hard palate is visible. So, we underwent a polysomnography. In polysomnography, his AHI is more than 40 per hour and in graph we could see an absent airflow which is more than 10 seconds. So, the patient has an obstructive sleep apnea. Another case scenario, a 5-year-old male brought by his parents due to a long-standing severe sleep disturbances and daytime behavioral issues. On examination, patient has a kissing tonsils and he has an adenoid enlargement and he has an macroglossia, which is nothing but a large tongue, and a micrognanthia. This is the one called as micrognanthia. So we done a polysomnography to the patient, and again we could see an absent airflow, that is obstructive sleep apnea, with an AHI of 30 per hour. So what are the risk factors for getting OSA? The first one is enlarged tissues, that is adenotonsillar hypertrophy and macroglossia. Craniofacial and jaw structures like retrognanthia or micrognanthia are narrow oropharyngeal spaces. Obesity and fat distribution like excessive body weight, increased neck circumferences and central fat distribution, and fluid retention around neck, which may be due to the heart or renal failure, and additional factors includes genetic and inherited syndromes and nasal congestion. Now we are moving on to why airway is frequently collapsible during sleep. The main important pathology is critical closing pressure. What is critical closing pressure? The critical closing pressure is a pressure inside the pharynx at which airway collapse. This peak crit may increase in cases of excessive fat deposition around the neck or obesity and other factors. So when peak crit, that is critical closing pressure, is very more, the airway become more collapsible. When peak crit is very low, the airway is more stable. So the critical closing pressure plays an important role in airway collapsibility. Why there is a frequent airway collapsing? This is basically due to the anatomy, that is pharyngeal airway are unsupported by bones. So the genioglossus and stylopharyngeus are the muscles which widen the pharyngeal airway. So during sleep they become more hypotonic, further compromising the airway. I am repeating the current slide. So in obstructive sleep pathology, the main pathology is at the pharyngeal wall, that is where there is a collapsibility is more. So when there is a complete obstruction, OSA occurs. The second important trait is ventricular control or loop gain. What is loop gain? The loop gain measures the stability of the breathing control system, that is chemoreflex. It quantify how strongly the body reacts to the disturbance in oxygen and carbon dioxide levels. For example, a high loop gain patient responds excessively even to small changes in the carbon dioxide. So the high loop gain people will have more tendency of getting OSA, while the low loop gain patient responds minimal to changes in carbon dioxide. So the high loop gain can be demonstrated in the following diagram. So there are two things here, that is A and B. A is a ventilatory response for a hypopnea patient in a normal patient. So here when there is an hypopnea, what happens now? There is a hypopnea. In normal individual it is very little. So what happens in high loop gain patients? So even a small decrease in oxygen or hypopnea will have an exaggerated breathing response though. So the same decrease in ventilation hypopnea leads to exaggerated ventilator response, which is due to the heightened chemosensitive PaCO2 changes resulting in cycling between hypopneas and apneas and hypopneas, thereby decreasing the ventilatory drive, leading to the decreased muscle tone, leading to an obstructive sleep apnea. So we will move on to the case scenario 3. A 40-year-old male with a BMI of 27 kg per meter square with a history of snoring and with a history of congestive cardiac failure came with the complaints of frequent night awakenings, excessive palpitation and breathlessness after sleep. So he diagnosed to have a congestive cardiac failure. In the view of symptoms of OSA, the patient undergone a polysomnography. In the polysomnography, his AHI was around 20 per hour. And you could see a drop in oxygen saturation and there is an absent airflow, that is OSA. So in congestive cardiac failure patients and genetic variants often has a high loop gain, which further worsen the obstructive sleep apnea. The third important physiological trait is low arousal threshold. What is this arousal threshold? The respiratory arousal threshold, which is usually measured in diaphragmatic EMG. Okay, the respiratory arousal threshold is defined as the level of ventilatory drive that triggers an arousal from the sleep at the termination of the respiratory events. So we have two thresholds, that is low arousal threshold and high arousal threshold. What happens in low arousal threshold? That is, in low arousal threshold, that is measured in diaphragm EMG. So the threshold, when threshold is very low, the patient has a frequent episodes of obstruction and frequent arousal. So this patient has an sleep fragmentation and frequent obstructive sleep apnea, that is the patient will snore multiple times. But what about in high arousal threshold? In high arousal threshold, the threshold will be high, so such that the obstruction and arousal will be very less compared to that of the low arousal threshold. So the low arousal threshold people has more tendency of getting obstructive sleep apnea, and symptoms will be more in low arousal threshold patients. So what are the consequences of low arousal threshold? There will be an increased sleep fragmentation awakened by every minor breathing disturbance, and there is also a reduced respiratory muscle activation. That is, premature arousal interrupts the natural respiratory drive, leading to pharyngeal muscle instability, and there will be a persistent fatigue and difficulty in concentration. A 55-year-old female who is a postmenopausal lady with a history of insomnia for past 10 years came with complaints of snoring with excessive night awakenings and excessive fatigue and tiredness despite the normal BMI. We underwent a polysomnography in which the patient has an obstructive sleep apnea with the AHI of 15 per hour. We could see the patient has a frequent arousal and frequent obstruction. So the in postmenopausal lady has a low arousal threshold, and the patient with insomnia also will have an frequent sleep fragmentation. The fourth important physiological trait is pharyngeal muscle responsiveness. You know, the hypoglossal nerve is crucial in controlling the tongue muscle movement, especially this genioglossus and styloglossus. So the hypoglossal nerve activity during sleep is less active, especially in old age and neurological conditions, so which will further trigger the OSA symptoms. So, a 65-year-old male with a history of CVA 2 years back came with the complaints of excessive sleepiness and snoring. On examination, his BMI was 33 kg per meter square. On physical examination, he showed right tongue muscle atrophy with deviation to right side on tongue protrusion. The patient is diagnosed to have a stroke. So, in this stroke patient, we done a polysomnography. In this polysomnography, we had an obstructive sleep apnea with AHI of more than 20 per hour. So, the causes for OSA could be due to aging and neurological disorders like stroke and myasthenia gravis. After explaining about the four physiological triads of OSA, we moving on to the pathophysiology of OSA. We already know in OSA there will be an increased upper airway collapsibility, and this increased upper airway collapsibility may be due to the multiple factors like morphological abnormalities, low arousal threshold, and unstable respiratory control, that is high loop gains and fluid accumulation around the upper airways and compromised craniofacial structures. All will lead to the decrease in upper airway dilator muscle activity, which leading to the obstructive sleep apnea. Along with this other pathophysiology, normal physiological conditions like during sleep, especially during REM, there is an exaggerated decrease in chemosensitivity and decrease in central respiratory neurons and decrease in ventilatory drive. So, further worsening the upper airway dilated muscle activity. So, especially in sleep, especially during REM stage, the OSA will be more pronounced. Okay. The obstructive sleep apnea is a vicious cycle. So, when the patient return to sleep, there is a reduced upper airway reactivity and increased upper airway resistance, resulting in reduce in lung volume, which leads to hypoventilation, and reduce upper airway muscle activity, which leads to upper airway narrowing and collapse, which leads to obstruction, and the patient will have spells of apnea and hypopnea. When there is apnea or obstruction, what happens now? The PO2 start to decrease and there is increase in PCO2, that is carbon dioxide. This carbon dioxide will trigger the CNS and the patient wake up. Once the patient wake up, what happens now? The upper airway reopens rapidly with increased upper airway dilator muscle activity. The patient will hyperventilate. When the patient hyperventilate, what happens now? PCO2 will move away fast and there will be increase in PO2 leading to return to sleep. This vicious cycle of OSA leads to dual stressors that damage the body, which leading to multiple consequences and comorbidities. The first one, intermittent hypoxia. The repeated oxygen fall leads to activation of inflammation and oxidative stress and sympathetic stretch. Every apnea is followed by an arousal leads to a sudden spike in adrenaline leading to sympathetic overactivity leading to more heart problems. The cardiac comorbidities includes hypertension. Why hypertension occurs in OSA patient? Because chronic inflammation leads to the endothelial dysfunction which worsen the hypertension, and the sympathetic, that is adrenaline overdrive, leads to persistent vasoconstriction which may further worsen the hypertension. Why this OSA patient has a arrhythmia and heart failure? Because the massive negative intrathoracic pressures during each apnea leads to stretching of a left atria leading to an atrial fibrillation, and the sympathetic drive leads to increased afterload leading to left heart failure. Endocrine abnormalities. The hypoxia and stress hormones leads to worsening of insulin resistance, and the sleep fragmentation leads to impaired glucose metabolism, and hypothyroidism also a risk factor. Liver and kidney problems. The inflammation, lipogenesis all leads to non-alcoholic fatty liver disease leading to liver cirrhosis, and chronic hypertension will have a nephrosclerosis and endarthritis of renal vessels, all finally leads to chronic renal failure. Mental health impairments. The mental health impairments includes depression, anxiety, sexual problems like loss of libido, neurocognitive impairment. The surgical and anesthetic risk includes increased perioperative risk because the patient is very fat and there will be a difficulty in intubation, and moreover there is immediate post-surgery cardiac risks, and the post-operative respiratory depression will be high because these OSA patients were highly sensitive to the sedatives. And safety risk. There will be an increased motor vehicle accident because of sleep fragmentation and decrease in sleep efficiency, and there is a increased workplace accidents, and there will be a social and relationship strains, and loud snoring also impair the quality of life of both the patient and the bed partners. The decreased seizure threshold in OSA patient will lead to more workspace accident due to the seizure activity. Summary. The obstructive sleep apnea is a sleep-related breathing disorder characteristic by recurrent episodes of upper airway collapse and obstruction during sleep. So, the upper respiratory tract evaluation, symptom evaluation and polysomnography are the crucial for diagnosing OSA. So, the OSA is not a single disease but a combination of 4 measurable physiological traits, that is endophenotypes. The 4 traits includes airway collapsibility, ventilatory control, arousal threshold and pharyngeal muscle responsiveness. So, the identifying the dominant trait helps in personalized treatment. Like for OSA, we will have a lot of treatment modalities which includes continued positive airway pressure therapy or some surgical advancement procedures or some medications. Thank you.